Sepsis has long been considered one of the greatest failures of modern therapeutics. Despite decades of research, almost every immunotherapy trial has failed. But a new randomized trial just tested something different: precision immunotherapy based on the patient's immune phenotype. At the same time, a large multicenter study challenges a common bedside practice in plural medicine. Should we clamp chest tubes before removing them? And finally, new SCCM guidelines revisit the role of neuromuscular blockade in ARDS, an intervention that many ICUs still debate. Today we'll break down these three studies and what they mean for daily pulmonary and critical care practice. Welcome to This Week in Pulmonary and Critical Care Medicine, where we review recent studies that have direct implications for clinical practice. Each episode focuses on a small number of papers that clinicians are most likely to encounter in real-world pulmonary and critical care medicine. The goal is simple: help busy physicians stay current without having to read hundreds of papers each month. Let's begin with the sepsis trial. Published in JAMA in March 2026, the ImmunoSep trial examined whether precision immunotherapy guided by immune biomarkers could improve outcomes in sepsis. Sepsis is fundamentally heterogeneous. Some patients experience overwhelming hyperinflammation, while others develop profound immune suppression. One hypothesis explaining decades of failed trials is that treating all septic patients with the same immunotherapy ignores this biological variability. The ImmunoSep investigators designed a trial to address this issue directly. The study enrolled adults with sepsis due to pneumonia or bacteremia across 33 hospitals in 6 European countries. 2 biomarkers were used to classify patients into immune phenotypes: ferritin levels and monocyte HLA-DR expression. These biomarkers identified 2 major immune states. The first was macrophage activation-like syndrome, representing hyperinflammation and characterized by ferritin levels greater than 4,420 nanograms per milliliter. The second was sepsis-induced immunoparalysis, defined by lower ferritin levels but reduced monocyte HLA-DR expression. Patients meeting these criteria were randomized to precision immunotherapy or placebo, in addition to standard sepsis care. The intervention depended on immune phenotype. Patients with macrophage activation syndrome received intravenous anakinra, I hope I'm pronouncing that right, an interleukin-1 receptor antagonist. Patients with immunoparalysis received recombinant interferon gamma, intended to stimulate immune function. Treatment continued for up to 15 days. The primary endpoint was improvement in organ dysfunction, defined as a decrease of at least 1.4 points in mean SOFA score by day 9. Of 672 patients screened, 281 were randomized, and 276 were included in the final analysis. The results were notable. The primary endpoint occurred in 35.1% of patients receiving precision immunotherapy, compared with 17.9% of patients receiving placebo. This represented an absolute difference of 17.2 percentage points, which was statistically significant. However, there was no statistically significant difference in 28-day mortality. Adverse events were generally similar between groups, although anemia was more common in patients receiving anakinra, and hemorrhage was slightly more frequent in those receiving interferon gamma. So how should clinicians interpret these findings? The key contribution of this trial is the demonstration that precision immunotherapy in sepsis is feasible and can influence organ dysfunction. But several limitations remain. First, nearly half of screened patients could not be classified into the immune phenotypes used in the trial, limiting applicability. Second, the biomarker testing required specialized laboratory techniques that are not widely available in most ICUs. And third, although organ dysfunction improved, the intervention did not reduce mortality. Nevertheless, this study represents an important step toward precision medicine in sepsis, an area that may shape future therapeutic strategies. The second study was published in Chest and examined the long-standing clinical question of whether chest tubes should be clamped before removal in pneumothorax management. Chest tube insertion is common in both primary and secondary spontaneous pneumothorax. However, deciding when and how to remove the tube remains surprisingly variable between clinicians and institutions. Some physicians routinely clamp the tube before removal. The idea behind clamping is that it acts as a trial of removal, allowing clinicians to detect persistent air leaks before the tube is actually removed. Others remove the tube without clamping, arguing that clamping adds unnecessary steps and may even introduce risk. To evaluate these strategies, investigators conducted a multicenter retrospective study across 27 centers in the United Kingdom. The study included 791 hospital admissions for spontaneous pneumothorax requiring intercostal chest drains. Clamping trials were performed in approximately one-third of patients, specifically 32.6% of cases. The primary outcome was recurrence of pneumothorax after chest tube removal. Overall, the 30-day recurrence rate was 13%. Importantly, recurrence rates were not significantly different between groups. Recurrence occurred in 14.0% of patients who underwent clamping and 20.6% of patients whose chest tubes were removed without clamping. This difference was not statistically significant. Clamping occasionally detected persistent air leaks. About 9.3% of clamped patients developed radiographic evidence of air reaccumulation during the clamping trial. However, this detection did not translate into improved clinical outcomes. Length of hospital stay was also similar between groups. Adverse events were rare, although one patient developed tension pneumothorax during a clamping trial. What makes this study clinically relevant is that it challenges a widely practiced but poorly studied bedside maneuver. The findings suggest that routine clamping before chest tube removal does not meaningfully reduce recurrence risk. Instead, clinicians may need to rely more on objective air leak monitoring and clinical judgment. Future research may focus on digital air leak monitoring systems, which could provide more precise information about pleural airflow and potentially improve chest tube management. The final paper is a 2026 guideline update from the Society of Critical Care Medicine, addressing the use of neuromuscular blocking agents in adults with ARDS. Neuromuscular blockade has long been used in ARDS to improve ventilator synchrony, oxygenation, and lung protective ventilation. However, evidence supporting routine use has been inconsistent. Earlier studies suggested mortality benefits, while more recent trials raised concerns about oversedation and ICU weakness. To clarify current practice, the Society of Critical Care Medicine convened a multidisciplinary panel that developed recommendations using the GRADE methodology. The panel addressed 5 key clinical questions related to neuromuscular blockade in ARDS. The most important question was whether neuromuscular blockade should be used at all. The panel issued a conditional recommendation suggesting the use of neuromuscular blocking agents in adults with ARDS who have a PaO2 over FiO2 ratio below 150 and remain hypoxemic or dysynchronous despite optimized sedation and ventilation. Importantly, the guideline emphasizes that clinicians should first optimize lung protective ventilation, sedation, and ventilator synchrony. If neuromuscular blockade is used, it should generally be limited to short durations, typically no more than 48 hours. The panel also examined other practical questions. These included whether fixed dosing or titration strategies should be used, and whether clinicians should monitor depth of paralysis using techniques such as train of 4 monitoring. For these questions, the evidence was insufficient to support a clear recommendation. Another area addressed was the use of neuromuscular blockade during prone ventilation. Again, the panel concluded that either approach may be reasonable depending on clinical circumstances. Overall, these guidelines reinforce a selective rather than routine approach to neuromuscular blockade in ARDS. Patients with severe hypoxemia or ventilator dysynchrony may benefit from short-term paralysis, but routine use in all ARDS patients is not supported by strong evidence. Those were 3 recent studies relevant to pulmonary and critical care practice. First, a randomized trial suggesting that biomarker-guided immunotherapy may improve organ dysfunction in sepsis. Second, a multicenter pleural study showing that routine chest tube clamping before removal may not reduce pneumothorax recurrence. And third, new SCCM guidelines supporting selective use of neuromuscular blockade in ARDS. If you found this review helpful, consider subscribing and sharing the episode with colleagues. And let me know which studies you would like to see covered in the next episode of This Week in Pulmonary and Critical Care Medicine.